You're watching The Role of a General Practice in Supporting Child Mental Health, produced by GP Supervision Australia and presented by Dr. Tim Jones and Matthew Byrne. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Welcome everyone along on the role of general practice, and as a training provider, really, your role as GP supervisors to support your registrars on looking after child mental health and more broadly parents and families of children who might have mental health issues. And it is through an organisation called Emerging Minds, a group I must say I wasn't familiar with, and I'm really excited to be able to introduce you to them and they'll be able to talk about their work and their role. So it's wonderful and thrilled to have you along. Tim and Matt, and in the background, Anya. My name's Simon Morgan, and I'm joining you from Awabakal country here in Newcastle, and I'm a medical educator and a GP here, and I actually work for the local Aboriginal Medical Service. And I'd like to ask Tim and Matt to introduce themselves, and then I'm going to disappear.
Thank you, Simon. It's lovely to be with everyone and to join you all. And I'm down here on Muwinina country here in Hobart, and I'm a GP, a rural generalist, a medical educator and a supervisor. And I'm here in this place tonight talking about this stuff for a couple of reasons. One, because I think this is such a needs-based area for our practice when it comes to serving our communities. There's so many families going through hard times and we're fairly closely located to them as GPs. I also am here because when I talk to my registrars, they find this incredibly challenging, and working out how to help them harness those GP skills to provide care in this area is one of my motivators. And lastly, I'm here just because I think wherever we work in Australia, we're aware of the access challenges around getting other supports in place. And so one of the focuses tonight is looking at how, as GPs, with our whole of family focus, whole of person focus, we can deliver really good outcomes in what we're doing to support the families we know and work with. And that's all from me for now.
Thanks, Tim. Hard to top. Yeah, my name's Matthew Byrne, and I'm a child mental health advisor for Emerging Minds. I'll talk a little bit about Emerging Minds. I've got a slide for us and I'll introduce Emerging Minds. But personally, a social worker by background, training in child development, child mental health. But I think I just wanted to reach over the professional divide, particularly being a social worker who lots of experience working with children. But I think we have similar roles when it comes to child mental health because we're both seen as that jack of all trades, wearing many hats. There's lots of different things that we need to cover in our role. Not quite any specific training like a child psychiatrist or psychologist might have around child mental health, but we see a lot of it in our day-to-day work. That in mind, and having done some supervising myself in social work settings, I think convincing younger practitioners that they do have those skills already to do a lot of this work is really important, and they can do a lot of this work that's needed, particularly with families. And I think what we're both good at across that professional divide is engaging with patients, with families, leaning on all those engagement skills we know already. So I think if you take anything away, it's to convince registrars that a lot of this work is relational, and so to lean into some of those relational skills. And that's what families, we do a lot of work with lived experience partners, and we ask them specifically about their experiences in general practice, and that's what they talk about, those relationships. Hopefully that's what you take away, that's one of the most important skills to this work, because I think often we come to this work thinking it's very complex and needing for us to do a lot of things and a lot of diagnosing of things, but a lot of the work is relational. We've got a few learning objectives. Hopefully we can reflect on the knowledge, confidence and skills in working with families to support child mental health. Explain the role of GP supervisors working with registrars to support child mental health in general practice, and discuss transferable skills that can be applied when working with children and families to support child mental health. So hopefully we cover off all of those things tonight. just talk a little bit about Emerging Minds. For those who don't know, we're funded by the Department of Health to lead the National Workforce Centre for Child Mental Health. There's a lot of different organisations who are part of that workforce, including people like the Parenting Research Centre. But mainly we're here to assist and resource organisations and workforces to understand their role in promoting infant and child mental health, implement structures, policies, practices that promote infant and child mental health, and identify continuous improvements and opportunities, and so much more. A lot of it is on our website. So if you jump on our website at Emerging Minds, you'll see a range of different resources for practitioners, for families, and for organisations as well. So there's so much content out there. A lot of it lived experience partners have helped us develop along the way. Even a lot of the GP content, even helping us with creating scenarios for role plays and all sorts of different bits and pieces. So we think it's pretty good content. A little bit about this is hopefully what we will cover. I've got a few slides on child mental health I wanted to go through. Tim's going to take us through a case study, and this case study is actually part of the guide that's officially put online on GPSA website. So hopefully you'll get a bit of a sense about what's involved in the teaching guide. We wanted to go through a few practice tools that might be useful for supervisors, but obviously some tools that might be useful for registrars as well. And hopefully I can talk a little bit to the content of the teaching guide as well. Child mental health in Australia. We know child mental health appears early. We know it's common across Australia, but we know that many families don't access help despite difficulties that they're facing. But that said, we know that GPs are an important place to access support. And in fact, we know that GPs are the first point of contact for families seeking support, closely followed by people in the paediatric space. We also know that mild symptoms are often missed or misinterpreted, and a lot of this work is building confidence in primary care workforce to engage families, and this engagement can therefore impact on the identification of support for children experiencing difficulties. We also know that registrars are most confident in managing physical presentations and least confident in managing mental health, behavioural and developmental presentations. That's a recent study that I came across, Caring for Kids survey. So it was a large cohort of registrars filling that out. So yeah, really interesting. Well, but what type of questions do you get asked as supervisors regarding child mental health presentations?
Concerns about self-harm or self-injury behaviour. I think that's quite common in my world as well too. I'll confess, when I'm working with registrars, particularly those who come fresh out into the community from working in the hospital context, the most common question I get is, who do I send this to? Who deals with this? Most commonly, we're talking about what we can do in this space, because again, I don't think people coming fresh out of hospital are necessarily aware that there isn't a ready and heavily accessible source of everything families need out there. We've got behaviour issues, what to say. When I'm talking to registrars who aren't parents themselves, they've often got a real sense of imposter syndrome. We can't talk to these vulnerable families about parenting because we're not parents. Asking for assessments of high-level neurodevelopmental concerns or conditions. Registrars coming to you as a supervisor and going like, we can't get this family into whatever the service we think their need is. What role can we play in the community? Not necessarily always trying to substitute for the entire health system, but trying to be part of really positive change as it happens as well. And it's all dovetailing with some of the other work we've done in this space, Matt, kind of pretty similar themes coming through. At the moment, my current main registrar that I supervise is moving out of their first term in the community into their second term. But I know when they started with me, they were sitting in with me for a consultation where we were engaging with a family with a few complex concerns. And prior to that consult, they'd expressed quite a lot of hesitation about seeing those presentations. They were feeling pretty apprehensive. After the consultation, I remember their reflection was just that everything I was giving as advice was, one, quite limited, and two, mostly in the space of just common sense. But most of what I was doing was reflecting their own experience back to them about everything that was going on and then supporting the family to make their own decisions. And the really nice thing for me as a supervisor was that was flowing back to me with, I can do that from the registrar, that they felt very comfortable to use their listening skills, their paraphrasing skills, their bringing it all together skills to do that, to be really non-judgmental about it too.
How to deal with parents who present with a child with behavioral problems, which obviously stems from the parents. I think we hear it a lot from GPs, but it's something that I'm quite familiar with as well. The good thing about my profession is I often have time with families. In one of my roles, I had 2 hours a week with a family, so a little bit different to this context. But I think being able to jump between working with a parent and working with a child is a really deep skill that requires lots of practice. And asking curious questions of the parent, asking curious questions of the child is really kind of important to this work.
And so one of the hopes that we cover, breaking down a bit of that, is we work with doctors from all backgrounds. We work with doctors from all sorts of varied experiences and with different styles of consultation as well. One of the common bits of feedback I get as a supervisor from registrars across all areas of health is that they like having a structure. You know, it's a bit like heads for our adolescent patient as a way of just getting across lots of areas of what's affecting that young person. And so one of the hopes we can cover is essentially giving structure to things it sounds like a lot of us are already doing. The experienced GP supervisors with long-term engagements with vulnerable people and families, it sounds like we're all already talking about some of the skills we use, but how we translate those skills into structure that our registrars can follow and that they can make sense of. Hopefully that's one of the areas we can cover, and hopefully it's the main area we can cover.
People asking increasingly about ADHD and autism. I've really noticed a shift in the last couple of years, particularly on social media and TikTok. I think families have the most access to information about child mental health and mental health generally than they ever have before. But I think the problem is that some of it is wrong, some of it is great. So they have more access to better information. And so I think we hear from a lot of GPs saying, parents are coming in saying, my child has this, we just need a referral, and that's kind of all we need from you. And how do you deal with that? Trying to find a space to slow down the conversation and ask more questions, be a bit curious, and just to unpack it a bit more before you send that referral out, because there's just a sea of information out there about mental health at the moment.
If we look at Leo, this is a very common case in my world at the moment as a GP working here in regional Tasmania. And I suspect there's going to be some themes that are common to your practice as well too. If you're happy to just read along with me, I'll pick out the key features. So we've got Leo's 4. He lives with his parents. Like everyone I see in my world, they're really trying to be good parents, but they're under a lot of financial and work-based pressures at the moment. And there's a younger 9-month-old sister in the home as well. Leo has the perception of being a very active child, but what the parents are noticing is that he doesn't seem to like to walk to the beat of other people's drum. He doesn't follow instructions well. He tends to run away if there's a request to do something. There's once or twice been a safety issue where he's run away in a public place, and his needs at night time are pretty high. He needs a lot from his parents to settle both in the evening and then through the course of the night. And at his preschool, the family's getting some perspectives from the educators that he's not a kid who likes to sit on the mat. What I'm hearing through all of that is that this is a family under strain. And this next bit is what I'm always seeing too. What medically could be going on is always a question that comes to me from families. Like, could they have an earache? Could they be cutting molars? Is there a hearing concern? What's going on? So that's one agenda coming up. But then the family also have this other agenda about what's going on with Leo's behavior and socialization. And let's just say that it's already a challenging consult. Maybe we've been running 20 minutes late and Leo's had some time to build up all his energy in the waiting room. And so he bounces in and starts practically taking your room apart, asking for snacks, trying to grab her phone, poking the 9-month-old. And you can see that there's a lot going on here. Anything I've missed in that stem, Matt, that is key to this case? I hope I've covered the majority of it.
Just to make a comment that it sounds like I feel like I'm there just by your description. So you've obviously lived this as well.
This is a decent chunk of my day at the moment, I think, regardless of whether I'm at home parenting our little ones or whether I'm working professionally. So it's nice to reflect on that because these are challenging consultations for any of us sometimes, particularly because it's hard to get an appointment. And so increasingly in my world, people are really getting to breaking point because they've waited a long time for the appointment, or they've just kind of rushed and booked something online and it's a 15-minute booking that they've come in with. I'd be really curious and keen to hear about just the general level of comfort or discomfort about that sort of presentation coming to you tomorrow as a GP.
This is a weekly consultation with me. It's a weekly thing, and I honestly don't feel comfortable with it, but I have to deal with it. So it's a very typical type of scenario you've presented.
Thank you for expressing that beautiful GP attitude of I don't feel comfortable, but I have to deal with it. I think that's a wonderful thing about our profession. We're there for whatever the community needs.
For me, and certainly for registrars, the observation is you can kind of muddle through often or do a fair job, but the end point of knowing where to send people if they need further assessment or indeed accessing it is often so difficult and challenging that it does make it a stressful encounter just because I don't know if we're particularly bad, but I imagine it's very similar across the country that access to sort of providers is so challenging.
Certainly putting on my chair of child and young person's health hat for the RACGP, when I talk to people all around Australia, everyone's having the same challenges. This is not a space where you could get ready tertiary level assessment or tertiary level support easily.
And I'm not sure how much you'll go into it, but there's always that fear of uncovering things, isn't there? And I think particularly for less experienced practitioners, just worrying that they're going to ask a question that uncovers something that they just struggle to know how to deal with or to how to respond to. Yeah. Sometimes means you don't investigate maybe sufficiently comprehensively. When I say investigate, just to explore that you might.
They're all really good points. And thank you, Simon. I think just riffing on that a little bit, something that my registrars would share with me is that they can sometimes see concerns that aren't even being raised by a family. They can see a family under strain and they can see that the parent-child relationship is starting to break down a little, or the communication is starting to be a bit more difficult between parent and child. And that's particularly when that Pandora's box effect comes up of, if I start asking about that, even with all of my thoughtfulness and my curiosity, is someone going to feel judged, or am I going to be opening a box that I then don't know what to do with? Or is it then going to blow out the next 45 minutes of my life when there's 3 other people waiting? It's really challenging to get across that. Matt, I know I tend to like to share a bit of my own experiences working with that concern, but does that come up in the social work sense as well?
Very much so. But I think having supervised a bunch of different social workers before, I think if you were to classify us, when you're supervising a social worker, it's about slowing them down because they would go straight for that. They would say, tell me about this, tell me about that. They would go for the deep, dark secrets. They would want to open Pandora's box, possibly because they've got a bit more time, but they do have a lot of curiosity. So a little bit different in that regard. But I think the underlying skill that I always try to instill is just to focus on what they might be saying there in the room right now to you, and attempting to put out all those things that you're going on in your frontal lobe and try and focus on what the parent's saying to you at that moment, or what the child is saying to you at that moment. I think is really important as well. A lot of parents are trying to maybe converse with you as a practitioner, and sometimes the child is saying something as well. Not to say that parents ignore their children, but sometimes it's good just to be modeling that, slowing down that pace to check in with the child, and sometimes that can make all the difference. That child bouncing off the walls, it may just be a bit of attention, but it may be something that's that observation there of seeing the interaction between the parent and the child and their relationship, I think is key as well. So there's a lot to kind of take in. If I was in that room, there's a lot of things that would be going through that in my mind. But most importantly, what are they saying to me? You know, are they saying I'm having a rough time and I need to feed that back, that I'm listening to that, and then try and get those questions in that I need to ask to get to where I think the conversation should be. So I think younger social workers, helping them slow down and relax, or attempt to relax in the moment, is probably the hardest thing, I think.
The clinician in the room is a role model. And one of the most powerful things you have when you've got a stressed family and Leo bouncing off the room in front of you is to just engage the child. Because as soon as Leo's happy and connected with you and starting to relax into the experience of being in your consult room, funnily enough, all the information you need to acquire to help you then work out the next steps you can take as the clinician is going to get a lot more easy. And you're going to have the parents much more able to communicate accurately what's going on in their perspective. And you've started to build a therapeutic relationship, an alliance that's going to be very protective and supportive of this ongoing work you do, whatever that may end up being. So I'm continuously leaning on my registrars if they're worried about the complexity of what's coming up, to still take that little bit of time, even if it means that other issues, less urgent things, some of that extra history taking has to be deferred to the next visit or the next visit, that the time you spend there will be time that pays you back many times over. And more than that, you've built an expectation of the family that you're a safe place, that you're trusted, that you know how to get along with their kid, and that they're going to be able to talk to you about whatever. You've broken down some of those barriers of shame, guilt, parental imposter syndrome, whatever it's going to be. The other thing, just remembering that if the families come to you and you're feeling overwhelmed by all of these things that are coming up, the family is definitely overwhelmed too. And so doing what Matt was talking about is wonderful junior social workers doing, of just, I've got to touch on everything. I've got to get across everything. They're not in a place that lets you do that. I'm always highlighting to my good GP trainees that the greatest strength we have is that we've got all the time in the world. It's just not in one appointment. And so figuring out what matters right now and letting the child and the family declare what that is, help them with that, and invite the ongoing relationship. You end up working still quite hard, but not quite as extremely hard. And you work a lot smarter too. You know, I've had consultations where I've got a twin sitting on my lap and I'm bouncing them, settling them while I'm getting history about what's going on for the other twin. I've had consultations where the kids are drawing me pictures of their teachers with demon horns to explain how they're feeling at school. You get so much good information out of the engagement. And sometimes things come up that the family hasn't even realized in terms of how their child's feeling and what their child thinks is going on. So it's such a powerful tool.
When I was saying that across that professional divide, I think the commonalities is we all have these transferable skills that I think are really important, but I don't think junior clinicians really think that. They're thinking, what they need to upskill in, or they don't know this, they don't know that. Thinking back to supervising social workers who were telling me I need to know more about ADHD, or because I'm working with this family, but trying to bring them back to some of these transferable skills that are listed here because they're most important. I think, like I said initially, that when we ask families what was most important when you had a supportive GP that got you through a 5-year stint of major challenges, and you've come through the other side, you've had many sessions with a child psychologist and you've managed issues and you're on this path where you're doing okay and the family's coping through all of that, what they remember is that secure base, all those listening skills, those hours that they've spent with the GPs listening to what's going on and saying things like, let's kind of work this out together, rather than a GP who is trying to solve all the problems and which are complex. Definitely in the social work field, I think really understanding that self-efficacy for families is really important too. So not to solve all their problems, but to help them kind of reflect on how they might be able to solve their own problems, or what sort of resources they might have already that might be helpful in this situation. So thinking about that story of Leo and him bouncing around the room, I wonder if for that next session whether mum might have some strategies that work at home that might work in the room as well. So, and that's all building that parental self-efficacy as well, because they've got lots of things that they can offer the situation. It's just kind of unpacking that, I think. So, yeah.
Thanks, Matt. I mean, if I was asked to boil down the top 3 skills I think GPs bring to this space, number 1 is reinforcing what Matt said. I think we're really good support people. We just innately understand that if you want to see really good long-term outcomes, you need to empower people. And if we want to burn out and deliver average medium-term outcomes, we try and solve everything ourselves. I think the second skill that we bring is our focus is always preventative. So, for example, if we see a family who we know experienced tremendous adversity in the first year of their child's life for whatever reason, and now they're going through that fairly lovely kind of 15 to 18-month-old phase where their kids are just really happy and their needs are all met and they're in a sunny spot, we can celebrate that with them, but we can also talk about the next phase, the 2-year-old tantrums or the 3-year-old emotional needs, and make sure that family feels empowered for what comes next, rather than just going, yep, all good, you don't need me, good luck, come back if you need me. We're always engaged with helping people prepare for whatever is to come. And then the last quality that I think we've got is that we can effortlessly move between a medical model and a more biopsychosocial model, depending on what's coming up. And I think that's a skill that is unique to general practice. If we see a registrar take a history of chest pain, they're in full medical model. If we see a GP take a history of someone experiencing persistent pain, they've got a little bit of medicine, but they're in full biopsychosocial mode normally, all of those different other factors that play a role. And child mental health is very much an area where those transferable skills are needed. If a kid's not concentrating in the classroom, we need to think about some medicine. We need to think about whether they might have hearing impairment or visual impairment or any of the language disorders or dyslexia. But then we also need to think about the whole biopsychosocial picture. What's the relationship like with teacher, with peers? What's the sleep like? What's that child's nutrition like? What's the way the material is presented to the child that the school wants them engaging with? And we can flick between them in a way that's very powerful. And they're all just questions. I really like using the persistent pain analogy when I work with my registrars, because innately, these good registrars we've got just understand that if you're dealing with someone who's living with long-term pain, you have to get to know the whole person and their whole story and context. And I just point out to them that this might present looking quite different, but the needs are the same. The way you position yourself to say, for me to help you and for me to help navigate the system with you and work out the best way of supporting you and your child in this situation, over time, I'm going to need to get to know all of those things. How do we go there? How do we share that? It's so nice to see the registrars just settle into that and go, oh, yeah, I can do that. I did that for so-and-so last week in a very different context.
I mean, maybe there's an assumption there of these skills being inherent and also applicable. But I think, and I'm hoping you agree, Tim and Matt, that supervisors have an opportunity to actually spell those out and walk their way through and say, you've got all these, and as opposed to having some confidence it's actually happening, which is nice, to actually reassure them that so much of what they're doing is based on an existing skill set. So I guess just to add to what you've said, that to be explicit, these are what those skills are. You're probably across most of them anyway, and that's why you're going to be an effective practitioner if you apply them.
Exactly right, Simon. That's actually what the situation needs.
Yeah.
It's not kind of, knowledge of which pediatric service has which wait time. Ultimately, good information in will equal smooth journey through.
Yeah.
Abbreviated information in equals long wait times, ugliness, and families getting more stressed, and also nothing positive happening. No families moving into the driver's seat of feeling empowered to be the agents of positive change for them and for their child.
Yeah.
Matt, let's talk perks. This is good fun.
So perks is one of our fancy little acronym, but it's one of our tools that we have out online. So I thought it might be the most applicable one. So I'll just quickly talk through it. And just to say, there's a few links on the teaching guide related to perks, and you can just jump on our website and type in perks and you'll find it as well. So it's just basically a list of domains, and it's a conversation guide or framework to help guide conversations with families. It's the main things that we should be focused on when we're thinking about child mental health. Very simply, parent-child relationship. We know from evidence that the parent-child relationship is the most powerful thing in terms of child mental health. So asking questions about what that relationship looks like. When we're talking about these different domains, it's really important to think about the strengths and also challenges as well. So I think often when working as a supervisor, helping not just focus on things that are going wrong in that family's life, but helping them find those places where things might be going right or might be a strength. So emotions and behaviors, obviously really important. Routines, fantastic to ask about routines for the child, but also the family. Again, thinking about what parts of those routines and thinking about the parent-child relationship, what parts of those routines are actually nurturing a parent-child relationship and what parts of those routines are really kind of putting that relationship under stress. So for Leo, it's those bedtimes when it's really kind of stressful, but, helping families look towards those parts of the routine that are really working to build that parent-child relationship. So communication and meaning making. So this is really how children communicate with and make sense of the world. And I think just to make the point here that we hear a lot of stories about when we think about parental vulnerabilities, so drug and alcohol problems, family domestic violence, even just parents who might be going through medical issues like cancer or something like that. It's really important to understand how the child makes sense of what's going on in the family and around them, because often they can make up their own story that revolves around themselves. So that, even in parent separation, that trope about, the child blaming themselves for the parent's separation is a good kind of one to articulate meaning making there. And then I probably don't need to talk more, but just support networks as well. And there's lots of different resources that use perks, but there's a really good conversation guide. But I thought it might be helpful to give a bit of structure, possibly to your supervision, but also to help get practitioners thinking about what might be important for conversations with families and where we might be able to identify what are the pain points and where are those kind of strengths that the family holds. And like I said, there's lots of links in the teaching guide for that.
I'm using
Yeah.
perks with registrars who are just getting started in this space and who are struggling with the engagement side of this challenge, and just want to know about what conversations they could be having that are useful, that are constructive, that are positive. Something I point out to them is that perks is useful across the whole spectrum of child mental health presentations. You can be dealing with someone who's in excellent mental health and you're being protective, and perks is useful. You can deal with someone in extreme levels of distress and whose family is in extreme levels of distress, and focusing on getting back to some elements of perks, even if it's just little positive routines or focusing on some meaning making, tremendously valuable. Because I think we overthink it sometimes about just how much it makes a difference. Like I was sharing about that idea of stepping out of the medical model into the biopsychosocial model, I really do point out to our trainees that a formulation is how we encapsulate all of that information in the eyes of ourselves and in the eyes of a family and of a child. And I really do love pointing out to registrars that because child mental health is so relational and so dynamic, small changes that are positive can have profound impacts. And compared to when we work in, say, adult mental health, where patients with long-term challenges can be long-term journeys to moving towards better health, it's always amazed me how just a few small little things happening that are positive in the world of a child can suddenly resolve the concerns. My favorite example is a kid who solved their own school avoidance behavior by just nominating that wearing purple undies made them feel brave. And just the act of them putting on their special purple undies every morning got them to school every single day, and with a very relieved looking family that all it cost them was a trip to the local Big W. So, because we talked at the start about structure, I just want to introduce a framework again coming from Emerging Minds that I use a lot in my practice, and I work with my more senior registrars who are starting to get into really doing the work with families. That child is my structure for formulation in these presentations. So C is the child's personality, their interests, what's going on. H is the home because it's the most important place a child finds themselves. I is the interactions. And sometimes I like to paraphrase that into not just interactions, but also what is the child perceiving to be the issues? What is the parent perceiving to be the issues? What is the school perceiving to be the issues? Where are they the same and where are they different? L is links in the community. And again, my special L is the learning environment, what's happening there. And then D is my brief developmental check, just to make sure that this child I'm working with is really, truly developmentally normal and that I'm not missing anything like a hearing impairment or other concerns that are really important to pick up early. And what I find really powerful about teaching registrars to do this is often by the time they've worked through that formulation with a family, so often the family has figured out what they're going to do next, or the child has nominated the area that they'd like to do next. And so you find as the practitioner, you're less stressed about trying to dictate the situation and far more in just that support role of going, yeah, that makes sense. I'd love to see what happens if you try that. How long do you want to give it a go for? And then you come back and you'll tell me and we'll see how things are going. This is, again, I love frameworks for registrars because once they learn the frameworks, it can become organic to their practice. And so if you've got registrars operating at different levels of comfort, if you've got registrars at different levels of engagement, we certainly hope these tools help. And with all of that, Matt, I guess I'll throw it back to you to bring it back to the teaching guide.
Yeah, so we've developed the teaching guide to really kind of revolve around that case study, Leo, that we've introduced, and perks. So for those who are going to jump into it and get something out of it, you'll be familiar with some of the content in it. There's a bit of pre-reading there. Again, it's a couple of our webinars that we think are more kind of introductory and useful for setting the scene about kind of what we've been talking about all night, about going back to those relational skills, all those sorts of things. And then we introduced the case study, Leo. There's a bit more detail to the case study than we talked about tonight. Then we introduced the idea of those perks domains to kind of really unpack that case study. And then we've given you a choice to either do activity 1 or activity 2, or do the activities in sequential order. So there's a pre-session planning using perks. So that's just going through that case study and unpacking Leo's situation using those domains. And then there's another activity for those who love to do role plays, or those registrars who might love doing role plays using perks. And it's really intended for you to also insert your own case study or the registrar's own case study as well. So hopefully that's helpful for you as well. There's a bit of structure there using that perks guide to throw into a case that you might have or your registrar might have. So yeah, a little bit of background to the teaching guide. And we're also interested in your feedback to the teaching guide as well. So that'd be great. Some additional resources you might be interested in. We've got a toolkit, a GP toolkit online that's got a range of different resources, webinars, etc., and e-learning. If you're interested or your registrars are interested, obviously CPD points are attached to that. And alongside that, Emerging Minds Families, we've got a host of different resources specifically for families. There's even some perks guides for families online. So there's a bit of symmetry there with some of our stuff online. Thank you. That's kind of all we've got time.
Thank you, Tim and Matt. Thank you so much. You've made this very practical and very much related to the supervisors' clinical experience and their teaching role and supporting registrars who often may struggle. And they're not going to walk into this with great confidence, but at least if they have some kind of framework, they're going to be able to navigate the consultation and, in a sense, giving them the out. They don't have to do it all in the one encounter. They don't have to come up with a diagnosis, but if they chip away and make a formulation, it's probably going to have a better outcome. I am going to very warmly thank you, Tim and Matt, for what I've found to be wonderful, a really good session. And I'm very excited to be able to, I think, refer people to this, because I can see this becoming a really useful place for supervisors and registrars to access. And also the teaching plan. And thank you so much for your work in pulling that together. It's wonderful to have that as part of our repository.
No worries.
Thank you.
Lovely. Thank you so much. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.